Okay, it's 12 o'clock right on the dot. I'm going to give everybody about 1 more minute to sign in before we get started. All right, we're going to go ahead and get started. Welcome, everyone. My name is Sarah Minirad, and I'm the PBRN coordinator with DO-Touch.NET. Thank you for joining us for this month's episode of Let's Talk About OMM Research. Before we begin, let's take a moment for the housekeeping rules of this webinar. If you have any technical issues during the webinar, please send a message to me, Jane Johnson, or Jessica Corrick. If you have any questions or comments during the presentation, please feel free to type them into the chat and as well address each other's questions in the comments there. After the presentation, we will have time for discussion and questions. If you would like to speak during the discussion, please raise your hand and we will unmute your microphone. We ask that you briefly introduce yourself and please feel free to turn on your camera. When contributing to the discussion, please limit the microphone time to 3 minutes to allow everyone time to speak that would like to participate. Please keep in mind that this webinar is being recorded and will be placed on the public DO-Touch.NET YouTube channel. Today is our Let's Talk About OMM Research DO-Touch.NET Network Update. Please help me welcome our Network Director, Dr. Brian Dagenhart, and our Associate Director, Ms. Jane Johnson. The floor is yours.
All right, well, thank you, Sarah. And let's see. Trying to see what screen is being shared right now. Doesn't look like it's the right one. Let me try this again. So, Steve, how's my new look? All right, very good.
Are you well? Or is this just a new look?
Well, you know, why am I? That is a great question. As soon as I get the right screen shared here, I will address that. But I want to. All right, now do you see some slides?
Yep, there you go.
There you go.
Great. All right, thank you. All right, well, so this past weekend, we had our annual Founders Day conference. And this year I was assigned to do a presentation on the osteopathic approach to death and dying. And it was a pretty challenging preparation. Took months to try to go back from Dr. Still's times to the current times in regards to what is an osteopathic approach to that phase of life. And so I decided on Friday before the presentation that I was going to enter into some of the experiences of that phase of life by losing kind of control of your looks, by having people look at you and wonder what's going on, talking behind your back about, you know, is he okay? All of these things. And so really helped me put into context some of the aspects of what I talked about during that presentation. So no, it is unbelievably cold. I'm growing it back as fast as I can as we approach winter here in Missouri. So, all right. Well, so today we're going to give you our autumn update for what we've been doing and what we're planning to do in DO-Touch.NET. And just as an overview, we're going to talk a little bit about the Advancing Skills in Osteopathy course that we had for DO-Touch members in August. We're going to talk about the continuing education credits that we give for our monthly webinars and journal clubs. We're going to talk about our upcoming research projects, particularly looking at the OMT registry and the long COVID study. Then we're going to look into our future for 2023. I'm going to talk about our annual meeting, the resident research enrichment program that we will be hosting, as well as our new website and public YouTube channels. So with that, the AT Still Research Institute, who has developed the Advancing Skills in Osteopathy program, has been very supportive of DO-Touch.NET towards providing their members easy access to our Advancing Skills in Osteopathy courses. These courses typically can either be 20 or 30 hours. We typically use for DO-Touch.NET a full 30-hour program, which is a 4-day course. And that is what we had this summer in August. These courses consist of evidence-based presentations on diagnostic palpation, assessment of skills throughout the course with detailed statistical analyses. In fact, we have 2 statisticians that are working throughout the week to turn around data for feedback regarding the information we're collecting from those who are participating in the program. We have a lot of palpation calibration exercises to help give reinforcement to refine the skills that we use as clinicians. And we use extensive technologies to provide objective feedback. And this is one of our more recently developed ones. This is using pressure sensors that allow us to look at feedback or actually even hear tones related to the levels of force that are being applied between the right and left thumb. And then we have a second computer that has 12 training modules on them that have been standardized and refined to help each person participate at a speed that is, most relevant for them. They can be very independent in their developing their calibration skills. So this is a group that we had in August, and this represents people throughout the United States, Italy, and Germany. We had 9 participants, and you would count here also 9 support staff. This is probably the most intensive program to put on than any conference that I've attended. Between the instrumentation and the support staff to run the instrumentation and give feedback to those attending makes this course unique and really probably the most advanced course that I am aware of going on within this field globally. Our 30-hour program, it consists of 5 hours of an intimate delving into the history of osteopathic medicine, which can really only be done here in Kirksville at the way in which we're able to do it here. We have time in the museum and in the archives to really, get one-on-one, hands-on exposure to the realities of what osteopathy was throughout its course in its history. We also have 5 hours of evidence-based lectures. We try to minimize lecture time, make sure we have enough context and background to do the work that we're doing, but we really want to give and focus on a lot of opportunities for participants to get hands-on skills to help refine and develop those skills. The cost for these programs is typically just under $1,500. But for DO-Touch.NET members, for those who have participated in these types of LTAOR meetings, our annual meeting, or our research projects, so those that are actively involved in DO-Touch.NET, they are able to get a 50% discount to the meeting. So I think that's quite a, considering all of the resources that are required for this meeting, it's quite a reduction that the Institute's offering. So this is as we are wrapping up with the meeting, and even after a very intense week, everybody was still feeling very energetic about the things that they learned and experienced during the week. Any questions about the ASO?
Mm-hmm.
Sorry. Yes, we have a question from Bill Brooks, whether for the future ones, whether CME will be offered.
We are certainly able to give CME for this, and it will depend upon the participants whether or not it is worth the effort to go through providing CME. And we're going to talk about that in just a minute. But yes, so the goal would be certainly with DO-Touch.NET sponsored ASOs that we would hope would be something that would be for CME credit. Okay, any other questions? Okay, thank you. All right, so we're going to move on now to let's talk about OMM research. This is a program we've been running now for a couple of years. From the beginning, we decided that this was going to be a monthly program to try to really engage membership in some type of routine activity that includes quarterly journal clubs, a quarterly webinar, and our quarterly PBRN update, which is what we're doing today. Now, as I said from the beginning, we thought as a benefit, a member benefit, that we would offer continuing education. Offering continuing education requires quite a bit of effort in order to meet the requirements of our granting agency, which in the end becomes the American Osteopathic Association. There's a significant upfront fee as well as a fee for every person that ends up getting CME credit. We did over the last 6 months an analysis over since the beginning of the program, how many people have requested CME credit, and we found that it was often just one person a meeting. And so as a result, unfortunately, because that when we look at a cost analysis of what we have to do in order to offer that, we have decided that we're going to discontinue CME credit at this moment. But if we have a large enough group that becomes interested in taking advantage of that offering, I think we'd be more than happy to reinitiate that in the future. Okay. Are there any questions about that?
Dr. Degenhart, I just want to reiterate that this is specific to LTAOR. CME would still be offered at the annual meeting and things like that, other events.
That's right. Thank you. All right. Okay, so now we're going to take a moment to look at the upcoming research projects. And with that, I'd like to turn the microphone over to Jane Johnson to give us an update on the OMT Patient Registry.
Hi, everybody. So we're still, I know we've given you a lot of updates on the OMT Patient Registry, and we're still moving along. We have a plan to start pilot testing the patient registry in 2 clinics for 2 particular physicians in the upcoming months. The plan is to get that started in December or January. And for those clinics to be able to provide some of their experiences at the upcoming annual meeting to help people, help you all understand what your patients are going to do and how the patient registry will actually function within your clinic, and what some of the patient experiences have been, and the clinician experiences, how people felt that this has impacted their healthcare. So that's the current status. Any questions on that? Okay, I'll turn it back to you, Brian.
All right, thanks, Jane. All right, so now we're going to give you an update on the OMM and long COVID syndrome study. Both of these studies have taken quite a bit of effort to pull together the infrastructure for them. And as Jane said, as you will hear for this one, we are planning in the very near future to get them launched. And so here's the update for the long COVID syndrome study. So our research question is how does manual medicine as performed by osteopathic clinicians impact people suffering and lingering symptoms after being affected by the SARS-CoV-2 virus? This is a prospective longitudinal cohort observational study. And our current status is that we have all of our online data collection tools completed and refined. We have gotten our IRB approval. We are finalizing our manual of procedures, and we are wanting to begin identifying clinic sites that would like to participate in this study beginning November 2022. We plan on having webinar informational sessions so that for those that know they're interested, they can come in and get the details. For those that are curious but not sure, that these also give an opportunity, to understand the full scope of what this study design is going to mean for their patients in their practice. So for those that are already know that they are interested in participating or interested in learning about more information on this, you can contact our network manager, Sarah, at her email address, and then she will inform you by email when we'll be scheduling our upcoming webinar. Are there any questions on that?
Yeah, are the criteria for long COVID well defined both subjectively and objectively? I don't have, I have a very low volume practice, and I have one patient who says she has long COVID, but I'm not in a position to adjudicate whether that's a correct label or not. So has that all been well defined in the study?
Yeah, we have used current standards from other studies and so forth to create the inclusion criteria. All right.
Oh, Dr. Degenhardt, I believe Dr. Downs has a question.
Okay.
Howdy. Nice haircut.
Hey, Jed, how are you?
Very good. All right. Couple things. I mean, one is that just yesterday, I think I read a very large, I think it was a British Medical Journal article that was done by the Germans, which lumped long COVID into basically 3 different kinds of clinical pictures, which would include, sort of brain fog, more of anxiety, and then the other one was sort of persistent chest pain. No, fatigue was one, persistent chest pain, shortness of breath, and then brain fog were sort of the 3 groups. And it was, based on a population of 50,000 people. So I thought it was relatively, it might be relatively informative to use that in terms of making the definitions. The other thing is, you know, the manual procedures, I'm curious as to what that's going to include, because in the people I've seen who post-COVID, some of whom don't have symptoms or some of whom do have symptoms, the ones I'm able to help the most are the ones that have the chest pain, shortness of breath kind of thing. And so I'm doing, you know, pleural releases, I'm doing pleural pericardial releases, I'm doing, you know, releases of the ligaments of the liver and that sort of thing. And so I'm wondering if that kind of stuff is being included in the manual procedures, or exactly what the scope of the manual procedures is going to include.
Yeah, excellent question. Thank you. First of all, if you could pass on that citation that you found, I would really like to have a copy of that.
Okay, yeah, it was something that I think that came up on Medscape or something, and I just followed the rabbit hole. I'll look for it.
Yeah,
Dr. Downs, I believe there are a few other members who would like that as well. If you want to send it to me, I can just send it out to the people attending.
That's Sarah?
Yep, that's me. Thank you, sir.
Yeah, great. Yeah, so that classification is consistent to some of the other literature that I have seen, but you know, to have a 50,000 population from which they have, you know, developed that pattern, that's a great reference to have. The manual of procedures is not one that is associated with the care of the patient. Okay, when you're talking about how each clinician chooses to care for their patients with this condition, that is a clinical decision that falls solely within the clinician's experience and license. That is not something that at all we are really trying to micromanage, so to speak. The manual of procedures basically talks about how do we run the research project itself. How do we recruit the patients? How do we inform the patients? How do we collect the data from patients and from the office? It is not involving the interventions that the clinician is providing. Okay, that would require an entirely different IRB setup than what we have. Is that clear? Okay. Any other questions?
So I don't know if I found the article. There's an article from the British Medical Journal called Long COVID, an Update for Primary Care. It was published September 22nd.
That's different than the one I read.
Okay. All right. Never mind then.
No, don't. Still download that for me, please, Jane.
Are there any objective data parameters at all, or is it all subjective? I mean, are O2 sats or any other things that can anchor the diagnosis of long COVID, or is it all entirely subjective?
So the surveys that are being used to follow like this central nervous system symptoms have been standardized, validated, and are being used for other conditions as well, like post-concussion syndrome. All of the symptoms related with post-COVID involving brain fog and those things are, I mean, it's identical to a post-concussion type headache syndrome. So we have used where we can objective patient report measures. Now, because we don't have a way to standardize across offices, whether they have pulse oximetry, whether the patients have pulse oximetry, so forth, we would love to have that information collected when it's available. But we don't feel we can standardize that across the study. We don't have the resources to do that centrally.
I don't see any other questions, sir.
Okay. Well, see, now that Jed's joined in, so, Steve, Jed, and me, Bill, that means you're next in line to bring on the look, okay?
For those attending, Dr.
What
Downs
the hell are
just
you
sent me
talking
the
about?
Dr. Downs just sent me the link, and I will post that in the comments here so you can download it.
All right, awesome. All right, so now we're going to begin looking at 2023. In 2023, I have kind of dubbed it the year of empowerment and production. And part of that is personal, part of that is just where we are at regarding the network itself. This past year, I've been in the process of stepping down from my position as director of the A.T. Still Research Institute. I do anticipate that probably by the end of the year that is going to occur. And the reason for that is administration is the best way to distract people from doing research-related activities. And what we're doing here in DO-Touch.NET and within A.T. Still Research Institute within the center that Dr. Snyder and I run is now way more important than trying just to uphold the Research Institute after it's now been in existence for 2 decades. 18 of them I have had to kind of sustain that. So I am hoping that 2023 will be clearly a unique year and set a precedence for DO-Touch.NET in regards to empowering our members to become actively involved and to get engaged in actual research activities. I mean, meeting monthly for these types of things are important, but we got to do our primary mission, and that is advancing the science and knowledge within this field, and that is through research. And so that is what I hope you will see when we look at the initial steps or time of 2023, that is what we are going to accomplish. So DO-Touch.NET annual meeting now for many years have been in conjunction or as a precursor to the AAO convocation. And this year, as in many years, it's going to be at the Broadmoor Resorts at Colorado Springs. And typically our meeting occurs the Wednesday before the start of the convocation. So convocation actually begins that evening with their opening reception. And our annual meeting is in that morning from 8 to noon. We do offer free CME for active DO-Touch.NET members. For those that are members but have not participated in activities, there will be reduced fees just for being a member. But for those that are non-members, they will be required to cover full cost, which is really covering our expenses for food and any technology that is necessary to put on this meeting. So it's still extremely inexpensive for the course. We are really, really excited about our keynote speaker this year, Dr. Jack Westfall. He is currently a family medicine specialist and consultant in Washington, D.C. His wife works, she's a dentist and works at NIH. They live right across the street from NIH. He has been actively involved at that level of healthcare policy, as well as trying to shape it through research. He is a graduate of Kansas School of Medicine and was faculty in the Department of Primary Care at the University of Colorado for 20 years. During that time, he has been instrumental in promoting research through practice-based research networks, particularly those focusing on rural healthcare and healthcare for the disadvantaged and so forth. He actually is born into a lineage of osteopathic physicians. He is certainly in every way has the osteopathic mentality to his core. I believe 2 or 3 members of his family were part of Dr. Still's class at the turn of the 20th century. There is documentation of his family members within the museum. So it's been validated. He hasn't just sold us a bill of goods so he could be our keynote speaker. Honestly, we've known Jack now for almost 20 years. Maybe Jane has known him for 20 years. He's part of NAPCRAG, the National Primary Care Research Group.
North American Primary Care Research Group.
Yeah, of which both Jane and I have participated in, and actually they through members of that organization, they helped us develop DO-Touch.NET through their group at Penn State University. So we're really excited about him joining us, and he is going to be talking about a very easy but very potentially impactful form of research called card studies. And he has helped to develop an online system to facilitate the use of this type of study. And he's going to be, first of all, he's going to begin educating us at our LTAR in February. So he will be doing our webinar in February about card studies. So we're strongly encouraging everyone who's going to be at our annual meeting to participate at the February meeting or to watch it on their own time, but to go through that presentation before coming to the meeting, because that's really going to facilitate us getting into what is most important, is defining the research projects and the research questions and the various ways that we are going to collect and the various measures that we will collect from our practices in a very, very simple manner. Jane, is there anything else you'd like to add to that?
Just a tiny bit of background. The reason they're called card studies is that they used to be done on index cards, and that's one of the things that makes them kind of a low burden research studies, is because it's 3 to 5 questions on an index card, and Jack and his colleagues have modernized that to be an app on one of these, so instead of paper. So we're really excited about this idea.
Yeah, we have actually, if we construct things correctly, we could be producing essentially a study every quarter. Okay, these aren't meant to be long, drawn out studies, which unfortunately that is what we have gravitated towards with DO-Touch.NET. And with the registry, I mean, these are complicated designs, takes a tremendous amount of time to construct and then to implement. These take us to an entirely new universe of opportunity. So in our era of empowerment and production, this is exactly going to help us to do that. And it's going to allow our members to generate a question that we can implement into a study design very quickly, very easily. So once again, we think this is going to be a great opportunity. In previous years, we've supported a resident research enrichment program, which we will do again this year on March 14th. So the Tuesday evening before our annual meeting. Jack Westfall will be supporting that particular meeting as well. And why DO-Touch.NET feels this is important is because we feel we got to build our future clinician researchers in our residency so that they can become the next generation members for DO-Touch.NET and to keep moving things along. So this program is free. We are subsidizing this completely for residents and I put here the neuromusculoskeletal medicine residents, but if they're a family medicine resident who has really integrated OMM into their work, we definitely would be encouraging them to participate, as well as their residency directors. All right, are there any questions about our annual meeting or the Resident Research Enrichment Program? All right. So I'm now going to pass the microphone on to Sarah.
Hi, everyone. So there are a few new people on here. So I'll just say again, I'm the PBRN coordinator. So if you're getting emails, it's usually from me. So face to a name. Thank you guys for joining us. So we've been working really hard on our website to make it more easier access and empower you guys to use it. Typically, we've had you log in and only when you're logged in, can you see the video? Can you comment? Can you continue the discussion from these webinars? We've tried to update the website to make it more simple, easier to use, and then you guys can access everything on the website without having to log in anymore. So it should be easier to use. And then also we've now made public our YouTube channel. So previously, the only way that you could see videos that we had posted on our YouTube was to log into our website and then link to YouTube and things like that. We've now made it all public. And with that, I just want to note that these webinars are recorded and they are put on YouTube, and now they are public. So the world can see these videos, just to keep that in mind whenever you're talking. But you're welcome to go to our YouTube now. You can watch anything on our YouTube, all of the previous webinars, all of our previous OMM minutes, all of our previous technique of the month, all of that is public now. You can watch it without having to log in first. And then you can go to the website. We've updated everything, all of our research is there, all of our public research is there, and then we now have a submission form for you guys to submit your ideas for your research ideas, so that we can talk about that with you guys and possibly get something going there too. So I encourage you to check out the website, check out our YouTube, and engage with us for sure. And then if you want to switch the slide, Dr. Dagenhart. So you've probably seen this, hopefully. This is our quarterly newsletter. I just sent it out last week, and you will be getting this at the end of every quarter. So you'll get one again in December. So at the end of the year, to kind of go over October, November, and December and everything that we're doing. But yeah, just look for this, and everything that we've been doing over the quarter will be recapped in these newsletters. So just keep an eye out for that for sure. Thanks, Dr. Dagenhart.
Well, thank you, Sarah. She is basically doing all of this work to keep us fresh and finding new ways to make engagement easier for our membership. So thank you so much for the great work that you're doing, Sarah. Just to let you all know, we have over 900 members now in DO-Touch.NET. I mean, that is humongous from an overall size. But, you know, for these meetings, we are averaging, 10, 15, maybe I think our best one was maybe 24 participants. So once again, this upcoming year, engagements, empowerment, production, that is what we are really striving for this year. And so we hope you are seeing these things as important and are finding ways to help to determine your niche in getting engaged in 2023. Okay, Jane, did you have a comment? I saw your finger raise up there.
Yeah. So there's a question in the chat from Hans about the long COVID study. How do we differentiate long COVID symptoms from long post-vaccination symptoms?
Yeah, from what I have seen in my review of the literature thus far, is it's primarily going to be based off of patient history and timing associated with onset of symptoms. I have not seen any other format. We don't have resources to do any advanced testing or so forth. We're going to have to just rely on timing of when positive tests were done onset of symptoms, persistent of symptoms, and so forth. Okay, so this is now an opportunity. I'm going to stop sharing and allow us all to kind of see each other and open up an opportunity for any of us to bring forth any ideas, questions, so forth.
Yeah, Bill Devine here. Hello, everybody. So I'll be lecturing first weekend in November again in Hamburg, Germany on post-COVID syndrome. And they seem to be very interested. With European research, I know in Germany, they have a problem linking with other nations. Is that correct for research?
Well, there are different laws in regards to privacy of information.
Yes.
And that is the biggest issue when we try to, build an infrastructure for research, is to make sure, we have covered everyone's unique laws along that line.
Oh, and then secondly, when it sounds like in December we'll be trying to put together the different sites for the long COVID study. Is that correct?
Yes, November and December we're going to be getting started.
I will have some colleagues at the Midwestern University Arizona clinic probably wanting to be involved with that. I've moved my private practice in with a physical medicine rehab group who have many patients. So, like Dr. Brooks said, my practice, I probably have only 6 long COVIDs in my manual medicine practice, but with the PM&R group, I think I might be able to pick up some in my private office now. But we will get together and catalog in December. Is that so? Keep me posted, please. That's all I have. And I'll report to you probably personally what I find in Germany.
Okay, thank you.
So
It's
Kate
great
had
to
asked,
see you, Kate. It's great to see you, Kate. Thanks for joining us today.
Unmute. Okay, there. Yes, thank you, Brian. It's good to be here. It's been just a challenging, couple of years, let alone the last month. So thank you all for your support. I am moving forward day by day. I got my little puppies, and for those of you who don't know, my wife passed away this last month after some home hospice, and so we're moving forward, and I'm hoping to get a small cash practice going out of my home in the near future. So happy to get my hands going again.
Great to hear that. And if we can be of help in any way, let us know. Okay. Okay. Any other questions or comments? Jane, is that your finger again?
yeah. I'm trying to interrupt without interrupting. So Kate had asked about the IRB for the long COVID study. So here in Kirksville, it's already been approved. And for any of you in private practice who don't have an IRB that you're responsible to, our IRB here has agreed to cover you. For those who are at a hospital or an academic institution that has their own IRB, we hope that your IRB would defer to ours, but sometimes they don't want to do that, and so, but we can help you with submitting an IRB application. So,
Yeah, I
All
believe,
right.
I'm sorry, go ahead.
Angelique here. Hi, everybody. I have not been active in the actual supply of data for a number of years. And so I'll probably need to talk with somebody specifically about if I am starting a private practice, I'm on paper, I don't have an EMR. Do I need an EMR to be able to participate and submit data? Okay. Good. So I'll talk to, who do I talk to get kind of set up again?
Yeah, so Sarah's the lady. She
Sarah,
will-
okay. The
She'll
other,
get you on the list for the webinar.
That's me.
Okay.
Yep.
great. Please, Sarah, can you send me an email?
Yes, I will.
Please,
Absolutely.
Please. Okay, make it easy. The other thing I wanted to ask with the long COVID, has anyone really seen the two indicators that my understanding for sarcoidosis is an ACE inhibitor elevation or ACE, angioconverting enzyme increase and then a lysosome enzyme increase. Is that at all characteristic in post-COVID? Are those enzymes being followed at all, or do they overlap? Bill, have you?
Yeah, actually, I have one patient with that, but there's a whole range of effects on patients, just like any other viral infection, and so some of them have certain immune things that they inherited, and of course they get hit harder than some of us that got COVID. And I got it for Christmas. Was bicycling 5 days after, but that was probably the BA.2 or form, Omicron. But and as far as response to the immunizations, there's a lot out there, a lot of study on that. I don't think our study can actually look at all of the different genetic types. And I'm sure Brian stated earlier, there are a lot of things out there on the filter on our study we don't have the ability to mark down. So my colleague on the Navajo reservation, I'll be interested in seeing his numbers when the study comes out. They had a lot of injury of those that survived COVID, and he's been treating it. So this will be a good study. I'm looking forward to December when we can all maybe do a Zoom meeting on it.
Yes, Jed.
I'm wondering if we need any kind of, electronic infrastructure in order to be able to participate. I mean, should we have a tablet that the patients can answer questions on, or, it would be directly inputted and that sort of thing. So, at this point in time, I have an EMR, but everything else is done on paper. So I'm curious.
Yeah, good question. Yeah, our goal is that all of our data is being collected electronically. So the surveys to the patients, those are going to be pre-scheduled and sent to their address of choice, and then we will then collect their information directly from them. We have essentially two standardized kind of forms that we've used in the past for previous studies that characterize the somatic dysfunction findings, characterize the treatment techniques that were used, and those can be filled in electronically and submitted in that format. So we really want to let go of a paper process that just significantly increases the amount of resources that are necessary to kind of process that data.
So my question remains, should I get a tablet so that I can have patients be able to fill these things out? Or, exactly, I assume the data is going to be transferred from my office to you as opposed to from the patient's home to you.
No, we are going to be, so this is the procedure. When a person comes in and is identified as somebody seeking manipulative care for post-COVID related symptoms, you as a clinician would inform them of the study. And if they sound interested, you will give them you will get their email address and give them a card that basically says that we will be contacting them in order to do an informed consent and to get them started. All of the data that they will be providing us will come from their own technology, okay? So whether their own computer, laptop, iPad, or cell phone. The only thing we want from the physician's office is kind of a brief summary of the overall progression of the person from time to time, and then the somatic dysfunction findings, treatments, interventions, and so forth.
And that will be forwarded to you. You'll get an email that says, okay, it's time to fill out this form electronically that provides us that information.
So my practice model is that I have somebody come in, I evaluate them, map them out, and then begin treatment right away. So there has to be a step of seeing somebody, saying to be able to find out if somebody's interested. I mean, I'm a solo practitioner, so I don't really have a means of pre-screening somebody. So I guess I'm not seeing the flow at this point.
Yeah, I mean, that's the reality of practice-based research networks. I mean, we're in the front lines, and people are coming into our office for care at that moment. And so basically, you make the diagnosis, you begin to lay out a whatever information, a course that you are recommending to your patient. You initiate that, and hopefully you also all at the same time, encourage them to participate in the study.
Yeah, Dr. Downs, at that moment, all you're doing is encouraging them to participate in the study. And then from there, I will contact them and sort of do that vetting process.
And they'll have already had one treatment.
That's fine.
Or more. Potentially, they could have been seeing you for a couple months, and we'd want to know how many treatments they've already had, things like that. But
well, so what are your beginning points to measure your endpoints?
Well, it's going to be so the surveys are have an actual a summary outcome measure that then will be compared periodically through the course of a treatment, a series of treatments. So those surveys are designed from whenever they enroll, that is their starting point, and then we will use that as a way of measuring progress over time.
Yeah, I'm concerned that there's a lot of treatment there's going to be recall bias issues.
What do you mean by that?
Well, so if you have treated somebody 3 or 4 times, then you're trying to get back at what their symptom complex was when they came in, and some of those symptoms have gone away, or whatever. I'm concerned that there's going to be recall bias as a criticism of the study.
Yeah, and unfortunately, that's just the accepted limitation of real practice. We tried in the very beginning to kind of do a more prospective design, beginning in the acute COVID situation. And unfortunately, we did not, we weren't successful in identifying enough people who are caring for people with acute COVID. So when it became clear that post-COVID was an entity, and at one point in time, we will look at some of the data that looks at the types of symptomatology that have been persisting and how that is common within the practice characteristics of people within DO-Touch.NET. It seemed just like that we definitely should be able to track and follow progression over time. And, you know, we will have different subgroups. We'll have people that may have been in, that came in fresh, that their symptoms are what drove them in, and we recruit them at their first visit. There'll be others that may have been taking treatments for 3-4 months, and we will, you know, analyze the data accordingly. All right, well, I think I'm going to pass things back over to Sarah for her to do her job. Hans, it's so good to see you. Thank you for joining us. Hans was part of our ASO group in August, so we really enjoyed his participation in that.
Yes, Hans, there before you logged in, he did a recap of the ASO, and there's lots of pictures of you, so you'll have to go to YouTube and watch it again. Okay, so we'll just wrap up real quick. I just want to mention that in November, we're having our educational webinar. You may have seen it in the welcome slides with Francesco Saratelli, and he'll be talking about the brain and body functions. And then in December, we'll be having a journal club with Dr. Regina Fleming. And so I encourage you guys to join us for those as well. And then we will see you in January for our next network update. Thank you guys so much for joining us today.